So we move on to the next session for the day, which is the last session, but a very important part of stroke neurology, which people tend to sometimes be more nihilistic about. But I think we've grown more in stroke neurology and ICH over the last decade, a faster journey. The first speaker for the day is Dr. Dar Daulat Shahi, a good friend. No, it's a pre-record. He's a good friend. We worked as fellows together in Calgary. He's got a very, very special interest in intracellular hemorrhage. In fact, he's one person whom I know who's really dedicated to ICH, both clinical and basic research. He's currently in the Ottawa Institute in Canada, and he's working a lot in ICH trials as well as in the ICH guidelines. He was not available for a talk in person because he's traveling, so we have his recorded talk. So can we please start his talk?
Hello, I'm Dar Daulat Shahi. I'm a stroke neurologist in Ontario, Ottawa, Canada. And I'll be speaking on spontaneous ICH, restarting antithrombotics. I do want to thank the Indian Stroke Association for this opportunity to present to you. I'd like to welcome you to the lecture, and I'd like to thank Professors Bhatia and Professor Padma for extending the invitation. I'll start with my disclosures. Most notably, I will be mentioning an ongoing clinical trial called Enrich AF. I am the Canadian national lead for that trial, and I will be making statements that are derived from the Canadian best practice guidelines for ICH management, and I was a member of that panel, as well as the American Heart Association's guidelines for the management of spontaneous ICH, the last version of which was 2015, and I will disclose that I'm part of the current committee. I'm unable to give you the actual guidelines because they are embargoed until 2022, but the statements I will be making will be sort of a blend of the two guidelines, and they will be in accordance with the guidelines that will be coming out. So my outline for today is to first of all touch on the recurrence risk and then get right into the restarting. And the restarting will be the antiplatelet therapies first, anticoagulation, thromboprophylaxis, and I am going to touch on blood pressure control, and you'll understand why when we get there. So first off, recurrence risk. When you're dealing with a patient that's had an ICH in an undifferentiated population, we can make some very...
Just a second. Sorry about that. There was a bit of a confusion at my end. Actually, we just kind of undo the series of the talks given. Apologies for that. The first talk is actually by Dr. Majaz Moonis. And I would request Majaz. Majaz, you have given the talk already recorded. So do we play the talk and then you will be there for live interaction? Yeah, so the first talk is by Dr. Majaz Moonis, and I've already introduced him. He's a colleague and friend from the University of Mass Medical School, and his special topic of today is non-hypertensive ICH. And we'll demonstrate his talk, and Dr. Majaz will be there for the live interaction as well.
It gives me great pleasure to be part of this summer school program organized by Dr. Vasamta Padma and Dr. Rohit Bhatia in conjunction with the Indian Stroke Association. I'm very thankful for having the possibility to give a talk here. And hopefully, the topic I'm going to talk about is non-hypertensive intracerebral hemorrhage. And I have no disclosures, essentially. So let me jump right into it. This is the typical etiology of intracerebral hemorrhage. Of course, which you can see, 48% of patients have hypertension. After that, in the elderly, the commonest reason is cerebral amyloid angiopathy, constituting about 17%. Vascular malformations, breathing disorders, tumors, medications, drugs of abuse, trauma, and then miscellaneous sort of occupy about 5 to 6% each. When we talk about intracerebral hemorrhage, hypertensive, Uh, there are typical locations that make you think of. So there are two things that go into this. Firstly, the person has to have hypertension, and he is usually fairly hypertensive at the time of the presentation. And the bleed is in very typical locations. The commonest site is the putamen, which is for 40 to 50% of all bleeds here, and then followed by lobar bleeds, um, thalamic bleeds, cerebellar bleeds, and then finally pontine bleeds. It's lucky for us that pontine bleeds are very low because they carry very high mortality as compared to all the other bleeds. So I'm going to present about 5 cases and go through the non-hypertensive intracerebral hemorrhages. The first case is a patient who's a 70-year-old man who presented with acute confusional state, disorganized, and had altered language and slow speech. His past medical history was significant for diabetes, hyperlipidemia, and lung cancer. Examination revealed disorientation, non-fluent dysphagia, but otherwise an intact neurological examination. So you have 2 pictures here. Anybody care to guess which is hypertensive or non-hypertensive? Well, if not, I can tell you this is a hypertensive bleed and this is a non-hypertensive bleed. The reason for that is that you can see a lot of, it's a classic location for a hypertensive bleed in the basal ganglia, subcortical. And you can see a spot sign, there's a lot of edema around it. This is how a hypertensive bleed occurs. On the other hand, if you look at the other bleed, it is non-hypertensive because there's very little edema around it. It is cortical based and not subcortical. So what is this? On looking at further imaging, which is an MRI, you can see that there are these multiple small microbleeds, which are all cortically based. The key element is the cortically based microbleeds all over the place. And so this bleed then becomes what is known as cerebral amyloid angiopathy, which is the commonest cause, as I said, of non-hypertensive hemorrhage in the older population. The clinical picture is out of proportion to the hemorrhage. As you can see, the person was just confused, didn't have any focal deficits, and yet there was a fairly big size bleed. Because it's not under high pressure, the damage done is very minimal compared to what it would have been with a hypertensive bleed. And therefore, the prognosis is better in terms of recovery. The real problem is that when you have cerebral angiopathy, you are 9 times more prone to bleeding in the brain from anticoagulation. For example, if you're on warfarin or apixaban or any of the newer drugs, it is something that would be of concern because you could have a major significant bleed in the brain, which could be fatal. And so when you have patients with atrial fibrillation and cerebral amyloid angiopathy, the combination is not uncommon at all. The two options that we choose are apixaban because it has the lowest rate of bleeding in this kind of particular situation. But if ideally what we should be doing is not go on anticoagulation at all, but use a Watchman device, which is a left atrial appendage occluder, which has been shown in the Crystal AF trial to reduce the risk of recurrent strokes by as much as warfarin does. So the advantage is that you do not have to use anticoagulation for life, which is a big saver. And we tend to be moving more and more towards the Watchman device as opposed to anticoagulation. This is just the Boston criteria for those who are interested in understanding what cerebral amyloid angiopathy is all about. So definite, which is autopsy based, probable, which is clinically based, and possible, which is again clinically based. There are other kinds of microbleeds that you can see, and these are subcortical. These are microbleeds that are in the subcortical region, They are not like the amyloid, cerebral amyloid angiopathy. And these macrobleeds carry much less risk of bleeding with anticoagulation, first of all. Secondly, they are more related to cardiovascular disease. So, for example, if you have microbleeds like this, it is somebody must be hypertensive, must have coronary artery disease, or things like that. But they do not increase the risk of dementia. They do not increase the risk of anticoagulation related bleeds as much as cerebral amyloid angiopathy. So, and they can be seen in a number of conditions. So cavernomas, for example, this is the classics. You can see the clue is a popcorn appearance of the bleed. There are multiple small bleeds in here. Hypertension can cause this. Radiation, you can see that there's a radiation site here. And then the bleed is, unfortunately, I can't move this right now, but anyway, the bleed was in that particular area. Microbleeds were there, and that caused brain hemorrhage there. And then infections. So the commonest infection that would cause this is bacterial endocarditis. Here's a second case of a 44-year-old female with known history of migraines who had a sudden episode of dizziness and shortly after developed severe headaches, more abrupt and intense compared to her usual migraines. An examination, she just appeared to be confused, minimal weakness of the left upper extremity, and no other deficits. A non-contrast CT scan was performed. And what we see is this, a small bleed in the fourth ventricle, intraventricular hemorrhage. Going forward, intraventricular hemorrhages can be of two types. They can be primary, which means that you do an angiogram and you do not find any particular source, or they can be secondary, where you do have a source. So in a large DSA, digital subtraction angiography series, it was found that patients usually present with altered mental status or headaches. Again, they don't present with any focal deficits as in the large majority. Primary and secondary we've talked about, but when they looked at the secondary causes, the commonest reason why people bleed in this area in a non-hypertensive situation is AVMs, 36%, and aneurysms for 58%. Others were bleeding disorders and some miscellaneous causes. The key point is that when you have pure intraventricular hemorrhage, you're obligated to do a CT angiogram first, and then if you don't find a source, then do a digital subtraction angiography or an angiogram, conventional angiogram, to see if there's a cause. As you can see in this particular case, there was a bleed and there was an aneurysm of the ICA, anterior inferior cerebral artery, which bled and caused this. So this was fixed, and therefore the problem was resolved. Primary intraventricular hemorrhages tend to be more hypertensive. They are larger bleeds. They may be associated with hydrocephalus. They may need drainage with the VP shunts, and often associated with oral anticoagulants and hypertension. So this is one study that showed that with primary intraventricular hemorrhage, hydrocephalus develops in 58%, and 37% of the patients actually required ventricular drainage, and 40%. In-house mortality was 41%. Third case is of a patient with COPD who has a 40-year back history of smoking, who developed high-grade fever, shortness of breath, and also had unintended weight loss of 10 pounds within the last year. Family history of intracerebral hemorrhage. Examination revealed a thin, emaciated man with normal aphasia and discontinuation and disorientation, with minimal left upper extremity pruned drift. Non-contrast CT scan showed a left frontal hemorrhage. And so you see this, the hemorrhage is there. And what you see is that this could have been either a primary tumor of the brain, it could have been an abscess, it could have been a vascular malformation. Now, how do you figure this out? We'll talk about that. The common brain tumors that cause bleeding are pituitary adenomas and pilocytic astrocytomas. Metastatic tumors, small cell carcinoma, renal, thyroid, melanoma, hepatocellular, and infections, which is bacterial endocarditis and abscesses. In this particular case, we found that there were multiple areas. There was another area of small bleed on the other side, and there was enhancement here around it. When you see that, the whole body PET-CT was done, which showed multiple metastatic diseases. And the patient was obviously in stage 4 cancer. Moving on to a second etiology, which could be an infectious, you can see that there's a small area of subarachnoid hemorrhage here. Taking the same scenario, this is non-aneurysmal, and this is a marker in some ways of that there's something else is going on, because aneurysmal bleeds occur in the peduncular area, and so this was then thought to be, because the patient had fever and chills, the mycotic aneurysms were thought to be the case because they were enhancing lesions. And you can see that there was a hemorrhagic conversion here on the GRA sequence, and an angiogram shows multiple small mycotic aneurysms. Important thing being that these patients should not ever be anticoagulated because there's a very high risk of bleeding in the brain. Another example of mycotic aneurysms, multiple small areas of microbleeds all over the brain. How do you differentiate tumors from infections? So in tumors, you have diffuse or no enhancement. In infection, you have ring enhancement. Leptomeningeal enhancement is common in infections, it's uncommon in tumors. Tumors behave as hypointense on T1 and hyperintense on T2, while infections just behave as hyperintense T2 rim. In angiogram, you can see a tumor blush sometimes. And on the MRI, in infections, you see subdural empyemas, mycotic aneurysms, or abscess that cause diffusion restriction. So you may have DWI positive images with or without a correlate on ADC maps. So when you see this kind of picture with the hyperintense T2 rim, leptomeningeal enhancement, ring enhancement, think about abscesses more than, or mycotic aneurysms more than tumors. This is the fourth case where 44-year-old male had a sudden onset of really bad headache and ataxia. He had a prior history of seizures, which is a big clue here. And he had an AVM. AVMs typically cause two kind of things, three actually things, that they would cause mass effect, they could cause progressive neurological deficits, they can cause headaches, seizures, and they can rupture. So you can see a classic aneurysm, AVM, and you can see the actual AVM site here. A second kind of bleed that you can have is called dural AV fistula, and these are actually made from venous sinus thrombosis and granulation tissue of venous sinus thrombosis, which develops these small, poorly supported vessels which rupture and can cause significant intracranial hemorrhage. Dural AV fistulas are about 10. I mean, if you think about AVMs, dural fistulas are 1/10 as common as AVMs. So they're not very common, but they can cause devastating hemorrhage, and they can be fixed once you define them with the angiogram. You can see the draining veins, draining areas into the subcortical region here. And again, you can see a large dural fistula with this right here. And again, this can be fixed with interventions. As I said, this is from sinus thrombosis, and it can cause subdural, parenchymal, or interventricular hemorrhage in various combinations. The important thing to remember is that they do not cause primary interventricular hemorrhage in isolation. The fourth, this is a patient who is a 48-year-old with frequent migraines and hypertension, developed sudden onset of severe headache while performing yoga. 2 days later, husband noticed that she was not talking nonsense and had gait imbalance. She went to the emergency department multiple times and was found to have was sent back home with migraine headache, with a diagnosis of migraine. Finally, they got a CT head of the, and what they found was on the end, there were multiple vasospasms on CT angiogram, and you can see that multiple areas of spasm are seen that did respond to nimodipine. And this is a condition of RCVS, which is basically a benign condition in the sense that it does reverse itself within 3 months. But in case within those 3 months, it can cause infarctions of the brain, it can cause subarachnoid hemorrhage, it can cause intracerebral hemorrhage as the 3 common manifestations. The treatment for this is not defined clearly, but most people use verapamil in long-acting verapamil in high doses. So that's the presentation of RCVS. Thunderclap, recurrent thunderclap headaches is the hallmark of RCVS, which is also seen in some other conditions like cerebral hemorrhage. It can also be seen with venous sinus thrombosis, etc. And as you can see, this is a case of large area of hemorrhage and venous sinus thrombosis. So think about veins also when you're talking about hemorrhages, brain hemorrhages, because in atypical location, lot of edema, and you can see that there is a thrombus clot sitting here in the transverse sinus. And you can see non-visualization of the transverse sinus on the right side, which is where the hemorrhage occurred. When should you suspect this? History of unprovoked deep vein thrombosis, pulmonary embolisms, patients on oral contraceptives, vasculitis, thrombophilia, or Beckett's disease, malignancy, pregnancy, ear infections or sinus discharges, states that excessive drinking, etc., that make people more dehydrated, raise ICP, focal radiologic clues are hemorrhagic infarction. Diagnosis is by CT venogram, MR venogram, or DSA. And embolectomy and decompressive hemorrhagectomy may be required for deep vein thrombosis. Anticoagulation should be done irrespective of the hemorrhagic infarct. Here's an example of hemorrhagic transformation. Small hemorrhage transformation, and these are called parenchymal hemorrhages, P1 and P2. P2 is one that causes mass effect and does require decompression sometimes. Okay, here's a woman with left-sided weakness, found to have occlusion of the ICA on one side, and the diagnosis should be fairly obvious with a history of strokes that she has this rete mirabilis, which I call moya disease. Progressive obliteration of the internal carotid arteries. So whenever you see a blocked artery on one side and a childhood history of watershed or strokes, you should be thinking of moya disease or moya syndrome. The treatment is STA, MCAS, anastomosis, and in children, encephaloduro-arteriosynangiosis is performed, which is very effective. Think of systemic vasculitis as a cause of bleeds sometimes. And in conclusion, I want to say that it's all in the history. Actual age, history of bleeding disorders, medication use, drugs of abuse, patients who present with thunderclap headaches, once or recurrent, patients who have seizures, new onset or progressive neurological deficits are suggestive of AV malformations. Urine toxic screen is very useful in patients who have no other history, because drugs like cocaine, etc., can cause intracerebral hemorrhage, and this can be an issue. Radiological vessel imaging is essential. If you see IC occlusion, you think of Moyamoya disease or some dissection related bleed. If you have vasospasm, you think of RCVS. If you have a cerebral venous sinus thrombosis, it's often missed on CTA and should be looked for carefully, because history tells you that there's a prothrombotic state and a person has a history of unusual clots before in the deep veins. And MRI microbleeds are often ignored and should make you think about either non-hypertensive or hypertensive bleeds, which is cerebral amyloid angiopathy or the others. Thank you. And I'll stop here. If you have any questions, I'll be happy to answer them.
Thank you, Dr. Majaz, for this wonderful lecture. I don't obviously see as of now any specific questions on the chat box or any question answers. So we can spend a couple of minutes fast. If anyone among the people live on the platform would like to ask Dr. Majaz any question, we would be happy to take. Or any comment. Magdi, any comments you have for this specifically?
You asking me?
Yeah, I was asking you if you have any specific comments to make regarding, this non-hypertensive ICH. This one specific question, Majaz, I would practically want to ask you is because sometimes it's difficult to convince the neuroradiology people to go ahead with an angiogram, especially if you have a youngish patient who is hypertensive also, and we find a bleed slightly atypical away from the usual hypertensive bleed site. So whether you would recommend angiogram in all these patients upfront, or you would ask for another imaging like an MR or another tool to have a lead before you want to do an angiogram?
So it depends on the situation. In most cases, you would do an MRI initially, and if it doesn't answer your question, you do the angiogram. Again, it depends on the location of the bleed. So if you're strongly thinking of a aneurysmal bleed, you would go very quickly for an angiogram.
Thank you very much.